Hi, everyone. Welcome to this month's webinar on integrating care pathways, exploring the building blocks for success. So it looks like people are just signing on now. We'll give it a moment. And while you're signing on, if you can open the chat and set your response to everyone in the chat box and let us know who you are and where you're from in the chat. So please introduce yourselves. Let us know where you're from. There we go. Now it's coming in. So Cecilia Craig from Durham OHT, Ethel McCantag from Scarborough Health Network, Kristen Scott from South Ontario Health at Home Management. Let's see, Marjorie Conan, welcome. Kathleen O'Connor, Linda Gilmore from Kawartha Lakes. Great. Keep introducing yourselves to let us know who's here. Summer Thorpe from Ontario Health West. Yes, welcome everybody. And again, if you're just signing on, please do set your responses to everyone in the chat box. And as we're going through the session today, please feel free to ask questions and make sure everyone sees it so we can all join in the conversation. So hello again. So on the next slide, before we do get started, I want to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Thank you. And next slide. So as we're all signing in here, welcome. We will start our next poll. So we always like to start out to see who has joined an HSPN webinar previously and who is joining for the first time today. And again, we've been running these webinars for a couple of years, but it always seems to get a few new people that are joining in with us to learn. And we'll just give you a minute to vote on that. And again, as you're signing on, welcome everybody, and please introduce yourself in the chat. All right, Trisha, when you see there's been enough responses, please do close the poll. Great. So 66% of people have been here before, and 34% is their first HSPN webinar event. Okay, so welcome to those who are joining us new today. I will mention that these the recording as well as materials will be posted on HSPN's website, as well as if you're interested in seeing some of the content before, that is also all up on our website. So please do have a look there. Next slide. So today's event, we're talking about integrated care pathways and exploring the building blocks for success. So here are our presenters today. We have quite a number of people, and I'll introduce them a little bit more right as they speak, but we are joined by quite a few people. So 3 OHTs and 1 program. And I will be your co-host today, along with my colleague Gaia. And you will notice Walter is not here. He is right now on the other side of the world, so a very awkward time for him. But Guy and I are happy to step in, and I think this will be a really interesting conversation and opportunity to learn from the teams. So on the next slide, we'll just get a sense of who is here in terms of what your relationships are with integrated clinical or care pathways. So she'll get you to launch the poll, and we can kind of see who's in our audience today. We know that OHTs, that integrated care pathways are being supported by Ontario Health, and it was part of the plan for the path forward. And so, but we have some that are started early in their development and some that are still in the planning phase. So let's see who's a part of our audience. We'll give it a little while longer. I can't actually see the responses coming in, so Trish, I'll get you to call it when it seems like we've had enough responses. Here we go. So a fairly even split. So we have about 20% involved in planning an ICP, about the same, slightly less, also involved in implementing an ICP. 30% are watching closely as other OHTs plan and implement their ICPs. So again, this webinar then is great for you because we're going to get to learn from 3 different OHTs and some of their work. Then we have 26% as a interested non-OHT observer, and 5% are here for the ride. So enjoy. And then our next poll, so this is for those who are planning or implementing an ICP, and we want to know what your focus was, or if you have multiple. So we know that some teams are focused on one particular ICP, where others are doing multiple. So it'd be nice to see what some of those are. And if you do respond other, you can feel free to comment on what that is in the chat. Great. And Trisha, when it looks like we have had a reasonable number of responses, or the responses are slowing down, please post that. There we go. So looks like the most common one is COPD. Just behind that, we have heart failure, and just behind that, lower limb preservations. And also a number of teams working on mental health and addictions, palliative care, diabetes, and slightly less with stroke, and some others as well. Great, thanks for sharing, everybody. So with that, I just want to highlight our agenda today. So we'll have a brief introduction, then we're going to learn from the OHT. So we'll hear from East Toronto Health Partners, Burlington, FLA, and then from an integrated care program. And then at the end, we're going to have some time for panel discussions. So you can ask your questions throughout in the chat, please do, and we'll take some, depending on timing, we'll take some pauses in between to ask questions of the teams. But we do have some time built at the end to really discuss between the teams and the programs, what are some of the essential success factors and key challenges, and really get into some discussion. So hoping everybody can stick around to the end for that. And with that, I will turn it over to Jeff Powis and Rishma Prennan from East Toronto Health Partners to present on their work. Thank you.
Wonderful. Thanks for the opportunity to present. So I'll be presenting. My name is Jeff with Rishma, who has been my co-lead with much of the integrated care work in East Toronto. And we wanted to share with you the East Toronto Health Partner experience. And we've entitled the talk a collaborative co-design approach to implementation. So next slide, please. So who are we in East Toronto? We're about 100 organizations, primary care, home care, hospitals, social service organizations with many patients, caregivers, community advisors included. We serve about 350,000 people in East Toronto, have a lot of diversity, 21 neighborhoods with about 50 languages spoken in 5 high priority equity deserving communities, of which Taylor, Massey, and Thorncliffe Park are 2 of our largest. Next slide, please. So certainly this group appreciates the challenge with chronic disease management and the impact it has in Ontario and the individuals suffering from chronic disease. We know that individuals with any number of the chronic disease listed in the priorities for Ontario Health, their diseases are exacerbated with these intermittent episodes of increased health need and frequent transitions between hospital and community care. And I think this really hit for me when we were doing some of our interviews with clients, and one of them described it as feeling as though after they left the hospital, they were in a choose your own adventure book. And really that lack of integration between those transition points allows really an opportunity for integrated care to make a difference. So this led to the excitement when we were given the opportunity to develop integrated care to try and see if we could figure this out for our clients. So next slide, please.
I'll talk about how we've tried to approach ourselves and really grounding ourselves in East Toronto Health Partners' core values. So we looked at East Toronto Health Partners with our partners, said, let's do some guiding principles. And the guiding principles is what we look at, and we still go back to ensure that as we design, implement, keep on iterating our integrated care pathways, we ensure that our guiding principles are our core of our foundation. So that's patient-centered care, health equity, really looking at evidence-based standards. So we looked at our clinicians, our specialists, our primary care, asking them what evidence-based standards do they like, they are using. We had a plethora of different evidence-based guidance. And so we really buckled down on the Canadian Thoracic Society, treatable traits, and the Canadian Cardiology Society to have that as some of our foundation to our integrated care pathway. And as Jeff mentioned, those seamless transitions, really looking at transitions and self-management to really empower our people in our community having these chronic diseases. We ensured that we had everyone's voices at the table. So our patients, our families, our caregivers with lived experience, our primary care, our specialists, our home care, our community providers, and then really looked at technology and ensuring we had digital experts at the table. Next slide. Our engagement include 150 different individuals, different people from across the different sectors, making sure that all voices were heard. Next slide. And we really wanted to do some meaningful co-design. So bringing our patients and our partners together, we had different workshops, we had design workshops, really looking at what is the art of the possible, what do we want to do? We further broke down into working groups, really trying to understand what is the need, what are the gaps, and what do we want to do at East Toronto Care Partners to really understand what integrated care pathways means for us and how we're going to position them, and really putting that patient and caregiver, those people in our community, at the center of all our engagements.
Next slide, please. So we felt it was important to do that work with our community to try and come to this consensus about where we go next. And, we wanted to try and operationalize the quintuple aim. And really, at the end of it, we wanted to build a lasting impact of integrated care, something that would be sustainable, people-driven, something that fostered and built internal capacity and delivered long-term value. And we thought it was important to come together to this conclusion because from here, we had to make some important next strategical decisions about where we went. We had to make the decision to use some of the existing kind of quote unquote off the shelf solutions for integrated care, or do we try and build an engine so that we could insert a multitude of future integrated care pathways? Again, our future vision is that we build this thing we've called EastCan, and we insert integrated care pathways that might be different disease states to get to an end goal where all care is better integrated, not just for specific disease states. And so we made the decision that we would spend the time up front to build our own East Toronto solution called EastCan, rather than use some existing solutions and hire those to do our work. Next slide, please.
So with that vision and understanding that we were going to build a program, starting with chronic diseases, but make it scalable. Make sure we're building an engine that can do a variety of integrated care pathways, but we'll start with where we had an opportunity with Ontario Health, with COPD, CHF. And what we did is really did a bunch of journey mapping. So looking at our people and doing their journeys with their chronic diseases. So we were able to do quite a few journey maps, focus groups with our people in our community, and understand where the gaps and their needs were, and really listening to the voices of those people. And then we worked with our partners to understand what programs and services are offered in East Toronto, where are our people getting their support for chronic diseases. So we did a partner asset mapping, which is really mapping out our programs and services, helping us understand what can we leverage, how can we leverage existing into the program, and how do we feel about building where there is no capacity or there's gaps. So really understanding current state to help us enable us to make sure that our patients have that integrated holistic care. So we did that in our co-development. Next slide. So our model that we came to after all the co-design, co-development was really called EastCan, as Jeff mentioned. And some of these features are having frontline staff, so our clinical care facilitator really doing some case management, our access administrator who is doing service navigation, making sure patients get the services that they need to support their journey, remote care monitoring and post-discharge support. And again, as I said, holistic self-management. So we're really looking at the medical part and medical management and medicine management, but also social determinants of health. Working with our people and our patients to understand what are their goals, what do they want to achieve, how do we empower them for self-management. We built in case management and progress reporting, so progress reporting with our people in the program. So ensuring they understand what are their goals, how are we working, how are we supporting them to get to their goals. Our progress reports are done on 1 month, 3 month, 6 month, 9 month, and 12-month basis. So really ensuring that we are working with our patients. We have digital enablers in place using our electronic medical records, and also ETHP has a shared care planning platform. So leveraging our shared care planning platform for care planning. Service connections using our asset map that we just mentioned in a slide before, and we have coordinated team-based rounds, all part of the program. Also part of the program, action plans, so for medication management, action plans for exacerbation management, and repeat follow-ups. We also enabled a lending program for equipment for patients to be able to have equipment to monitor their chronic diseases, specifically for COPD, CHF. That includes a blood pressure monitor, oximeter, scale, and also an e-reader that has patient education materials on the e-reader. So just at the bottom here with our visuals, just to show how we did this. So we really wanted to clarify the vision and what was our ideal future state. We wanted to build that engine. We wanted to really leverage data and evidence-based guidance. We wanted to build out our program, but we wanted to do it in a phased approach. We really felt that we can start small and keep on working upwards. So we started with COPD, we started with hospital admissions, we moved out to CHF, and then we moved to community primary care referrals. And really a core foundation of our program is to test and iterate. So really build it, test it, iterate it. So constantly looking for improvement opportunities and keep on that rapid cycle improvement. The next slide. This is how we just built and implemented. So I won't go through this in detail, but we really wanted to understand how we're going to build our engine and then how we're going to implement it. So looking at the key features that we needed and the key parts of project management, the processes, tools, our staffing, our technology, looking at communications, and ultimately change management as we implement it. Next slide. So we're able to launch East Toronto Care Network. So we're very proud of this work. It's really the service delivery arm of East Toronto Health Partners. There's our website for future reference and just showing you some of the patient information through our integrated care pathway folders and then our equipment lending program. Next slide. This is a visual of East Toronto Care Network, so I won't go through this in much detail, but these are the features of the program. So right now we have our integrated care pathways with our clinical care facilitator. Our clinical care facilitator really working with that circle of care and the different people and providers that are part of that care plan. And we also have rounding tables. So rounding tables is really for people with unmet health and social needs. And they are brought to the tables, they occur about twice a month with different providers at the table, and it's a case management. We're looking at case rounding to really help support people who are not getting what they need or having troubles or challenges, barriers within their care plan. Next slide. Using that, we also wanted to map our health quality Ontario standards. So we looked at all the health quality standards and said, how are we making sure we're check marking all these standards within our pathway? So this is just us putting our stars with our health quality Ontario standards into the pathway and ensuring that we're meeting all of them. And the same for the next slide, which is CHF. We can show that one quickly as well. And there's our CHF, mapping out our health quality Ontario standards for CHF as well.
The next slide, please. So in keeping with our desire for iterative improvement, we use an operational dashboard at our Q2 weekly clinical and operational team meetings. We review the number of people who have been approached to consent. Again, we are consenting people at present from hospital admission with one of COPD or CHF, and are now having people referred in from more community-based sources, primary care and other specialists. So we're able to review how many were approached, how many consented, how many were enrolled. We can also review escalations and ED avoidance, and then particularly important, look at the top services that are being requested by our interactions and how do we potentially build better systems to make sure those needs are met. Next slide, please. Appreciating that many of the metrics that HSPN and others are looking at are going to take time to hit, readmission rates and such. We did want to make sure we collected patient stories. And, when thinking back to our patient-centric building, we wanted to ensure that we captured these adequately. And I won't read all these explicitly, but, just looking at the first patient, we often forget about palliative care in chronic disease management, but it is one of the health quality standards that's critical. And it was a COPD patient who was really struggling, recurrent hospital admissions, which was not ideal at their end of life. And we were able to facilitate in-home assessments and have subsequently prevented readmission, which has improved their end of life care substantially. So next slide. So just in closing, we feel we've built a scalable solution. And this has improved East Toronto's system capacity. We are hoping to expand to future pathways. We did do planning for lower limb and hoping to introduce that. We were lucky enough to receive some funding for a ventilation program. And again, our desire is to pull everything into this operational arm of East Toronto Health Partners. So we pulled the post-ventilation program into that as well. And then desires for mental health and palliative care as well. The hospital has redone its strategic plan. Integrated care is really prominently present, and ETHP is refreshing its strategic plan. And again, integrated care is a strong vision for the entire group of partners. In addition to the evaluation that's being done by the ministry, we are also doing patient-provider journey mapping just to stay true to our vision of doing what's right for the patients and providers. And also looking at healthcare utilization more locally compared from the previous temporal past to present after enrollment to see if there's a change in healthcare utilization. So thank you everyone for your attention, and we'll conclude our presentation there.
Great, thanks so much, Jeff and Rishma. But there's a number of questions that are in the chat. I think in terms of timing, I might just get you to comment on the one, which was just about sort of choosing that homegrown or your own solution instead of focusing on an off-the-shelf one, and just some comments on that. And then perhaps after that, there are quite a few comments, but maybe we can get you to respond to those in the chat while the other speakers are presenting.
Great, we're happy to do that. I did say something in the chat about the reason to choose our own solution. We knew it would be slower. We'd have to hire our own staff. We'd have to build our own pathways, still build our own digital solutions. We had some of those things leveraged already that we could lean on to get there faster, but it still left us to an endpoint in a slower way. But we felt that was important because it was the collective vision of the entire group to get to this bigger system. It was actually the group that told us, build the engine, and then we're going to build a bigger vision of integrated care across East Toronto. And so it was slower to get to a point. We thought it was worth that upfront investment so that we could grow what we want to grow in the integrated care pathways. Actually, our vision is not integrated care pathways, it's integrated care. We'd like to get away from disease-specific integrated care pathways and really make it about better integrated care, particularly at times of transition. Home care, so community care to hospital, long-term care to hospital, hospital to community, all these different transitions is where integrated care for more complex patients tends to fall.
Okay. Yeah, thank you for your reflections on that, and have a look at, there's quite a few questions in the chat, so have a look there. So next, we'll be turning it over to Burlington OHT. So we'll hear from Dr. Rihim Abdelhalim and Abby Regni.
Thank you so much, Carol. Next, please. So the Burlington OHT was one of the initial OHTs to receive approval in 2019 to become an OHT. In late 2023, the Burlington Ontario Health Team was identified as one of the accelerated I-12 OHTs, and this means that they will be just like given more resources to provide a little bit more care. And the first thing that the OHTs were required to work on is actually creating integrated clinical pathways for two chronic conditions, COPD and heart failure. A little bit before that, maybe a year and a half, some of the OHTs were piloted to work on integrated clinical pathways for COPD and heart failure. However, the Burlington OHT was not one of them. So last year, this was our very first experience to work on any clinical pathways. Our approach within the Burlington OHT to design any new initiatives is actually co-designing. And when we say co-designing, we include the majority of the stakeholders in our community, as well as patients and caregivers. The goal was to create integrated care pathways that will look at the entire disease trajectory. So thinking about prevention and early detection all the way until palliation. Also, we were interested in looking at ways to facilitate care across various health and social care settings. So paying attention to social terms of health was also a priority. Next, please. What we did, just very similar to what Jeff and Reshma did, we did engagement with our community. So during this extensive community engagement, we spoke with about 70 key informants representing providers and provider organizations, as well as patients and caregivers. And we conducted about 100 hours of engagement. It's important to note that some of these activities, the engagement activities, were co-facilitated with two other OHTs, the Greater Hamilton Health Network, as well as Middlesex London OHTs, who were tasked by the same task of creating clinical pathways for COPD and heart failure. And we do have some pre-existing relationships with them in terms of working together. And also, the three of us belong to Ontario Health West in terms of geography. Next, please. The outcome of the engagement work was actually understanding what are the guiding principles when we're thinking about co-designing and implementing pathways for COPD and heart failure. For us, we decided that we are building care pathways and not clinical pathways, and I'm going to come to this in a minute. Also, our pathways are person-centered, evidence-based, standardized, yet adaptable, provider-friendly, and we are targeting all individuals, not the top of the pyramid of the population health. And we are trying to co-design pathways that are easy to adapt by our providers, equitable, and sustainable. Next, please. So how do we view our care pathways, and why did we decide to create care pathways and not clinical pathways? So for us, a care pathway focuses on the majority, if not all, of the individuals living with a chronic disease, rather than focusing on a segment or two. And also, a care pathway would pay special attention to upstream interventions, so thinking about prevention, early detection, as well as management. And also, a care pathway would be addressing clinical and non-clinical needs of individuals living with a particular chronic condition, and it recognizes the intersection between different chronic disease, as well as physical, psychological, and mental factors that would affect the outcomes of these chronic conditions. Next, please. The other findings, other than the importance of looking at a care pathway other than a clinical pathway, so our stakeholders identified that we do have so many programs that are already existing within our community. However, they're still silent, and the awareness about them is very challenging, whether to our providers or patients. So there was a request to, can we please have all these programs listed somewhere? Also, our primary care providers said that they lack access to consistent evidence-based resources. And by that, they meant that there are quality standards out there. Sometimes they check it, but it's not easy for them to check the quality standards with each and every patient. So is there a way to make this easier? Also, whenever there is a change in the quality standards, most of the time they don't get updated about that. So how can we help them get the most recent and updated data that would support the management of their patients? Also, coordination across different settings was a big gap. And the supports that are needed to promote self-management and patient education as active partners in the management of chronic disease was a big gap. Next, please. For us, in order to put all these findings together, our ultimate goal was to create an integrated system for chronic disease prevention and management. And for that, you can think about two distinctive components. A digital enabler that would support our providers in terms of the knowledge awareness, listing of the programs, how to do referrals, eligibility criteria, when and where and how to refer the patients, as well as an interdisciplinary team that would include all the functions that are lacking within an integrated care system that is currently in place. So as mentioned by our stakeholders, there are so many siloed interventions. So for instance, there are remote care management programs, but does everyone knows about them? And do they accept everyone? No. System navigation, both for providers and patients. There are some buckets in our community that do amazing system navigation, but it's not for everyone. And also there was a need to think about how to increase the capacity of all the community services that are serving individuals living with chronic disease. But the most interesting piece was about how to put all this within a system that would be efficient and sustainable. And for that, I will leave you with Abby Ragmi, my colleague.
Thank you, Reham. Next slide, please. So as Reham mentioned, we got into the engagement phases with our partners in the West here with Middlesex London and Greater Hamilton Health Network OHTs. And through that collaboration, a decision was made to enter an RFP process together as well, having all the findings that Reham just explained. Through our engagements, we put together a pretty robust requirements document, evaluation criteria, and then we entered a RFP process to find a solution, a digital solution that would check all, most if not all, the boxes that we're looking for. Next slide, please. And we successfully went through that process and have and did identify health pathways as the winner of obviously the RFP process, and that is the platform that we're using to house our or to build our care pathways with. Each pathway within this health pathways platform have clear and concise steps for assessing, managing, and referring patients. And really, it is a provider-facing solution that is designed to be used at the point of care for primary care providers, which will include family physicians, NPs, and allied health professionals also. So next slide, please. And then for the implementation of health pathways, as a tri-OHT team, we've really come together to collaborate on this solution and implementation. So we have a collaborative governance table. We have a pathway selection methodology and a table. These are all kind of work streams that we've established for successful implementation. Obviously, integral part of that being communications and engagement, and also a very robust evaluation plan that has been put in place right from the very beginning. Thank you. Next slide, please. Okay, so we talked so much about collaboration, and really it has been a collaboration across the tri-OHT team, as well as, the health pathway, in choosing health pathways as a solution. One of the main benefits of this platform is that, when we're looking at developing these pathways, there are existing pathways already on the platform, about 600 plus pathways that are already existing that have been used in New Zealand and Wales and across parts of Australia and other parts of the United Kingdom. And to draw from that pool of already existing care pathways and to be able to localize that to our context was one of the things that really attracted us to this platform. So this allows for looking at the content and and really necessitating conversations between the primary care and secondary care, and come to an agreement, a bit of a local agreement that this is how we're going to do things around here. So, in taking an existing pathway, in enabling those conversations between our primary and secondary care providers, and in arriving at a common way to do things around here is what is really meant excessive collaboration across all of those levels. Doctors and other health professionals with experience in the pathway are involved in compiling and adapting content. So when we're talking about localization, we have clinical editors who are family physicians in the community already working, actually writing these pathways or revising also. And then we've got a technical writing team from Health Pathways that are supporting with the design and writing as well. So our goal for June of 2025 is to have 40 to 50 care pathways that are going to be reviewed, localized, and published to our region by June of 2025. Next slide, please. So just real quick on the value proposition of the Health Pathways platform. Again, easy to use. It's used for designed for point of care. It's a single access point for the single access point. It ensures simplified access to clinical guidance in real time. Really saving time for our primary care physicians on having to go to multiple places to look for this information, because not only does it house clinical guidance, it also has resources that are, and with referral pages, referral forms, etc., all in one place, and also patient education resources. So it really is a one-stop shop for our providers, and it really continues to foster collaboration across specialties, allowing more coordinated care and greater options, and obviously as a result of that, reducing variations in care. Next slide, please. So yeah, so we're in development. This is kind of a preview of what our pathways page will look like for the providers. Burlington Community Health Pathways, as you can see, still under construction, but this is a view of our draft page. Next slide, please. Yeah, and then we want to leave you with some take-home messages really from the engagement, from the work that we're doing of Health Pathways implementation. The biggest one being here, engagement. We can't stress enough how that's been so important in all aspects of our community, from the provider as well as patients, as well as leadership within the various organizations that represent the healthcare system. Engage as much as you can. And then implementing, best practices within integrated care requires obviously tweaking, tailoring, and adaptation. And our collaborative approaches among integrated care networks can facilitate innovation and forward thinking. So we're seeing that, as a result of all of these conversations that are going on between our specialists and our primary care providers when we're developing the pathways. And I think this is my last slide. Next slide, please. Oh yeah, so just leaving you with our contact if you need to reach us at any point. Thank you so much.
Great. Thank you, Riham and Abby. Very well done. So we'll get, if there are any questions in the chat, please feel free to ask. But I'm curious, you mentioned sort of the engagement. It's very clear that from the beginning, there was that generative co-design. I'm wondering if you can comment a little bit on sort of the engagement plan going forward as things are sort of implemented and sustained.
That's a great question, Carol. So in terms of engagement for sustainability, it's a multi-pronged plan. So this is a huge intervention that would affect multiple stakeholders, not just primary care providers. So once we start listing, for instance, referral sources, you would expect that the sources that the primary care providers are referring to are ready and engaged. And also all the data and information on the website is updated and managed properly. So that's one level, just to make sure that every single line in the platform we have some relationship with these organizations. The other level of engagement is actually engagement with our primary care providers and specialists, because they are the creators of the content. And in order to make sure that there is a sustainability plan, continuous engagement with our primary care providers and specialists will be happening each and every day of our lives until this platform is up and running. The other one is just engagement with our local providers generally, not just the creators, but the adopters, the users of the pathways. We have a very robust communication plan that goes every month in a newsletter speaking about how are we doing, what are the pathways that are coming their way, how are we launching, how to onboard them, what are the needed steps that they need to be going through in order to have access. These are all things that are going every single day of our lives now, just because sustainability of such a great platform will take lots of time and effort as well.
And just maybe just to add to that, the platform itself is built for very easy access to providing feedback. So there will be opportunities, and we see this as an iterative process of trying to make this better with every iteration. So it's not a one and done for sure. And like we said, there's over 600 pathways already available on the platform for us to localize. So we're only tackling about 50 by June, and very much see this as an iterative program that runs for a little bit. Well, obviously funding dependent, but yeah, there's quite a few ways to engage and provide feedback for the providers themselves through the platform as well.
Great, thanks. So I think there's a couple of questions in the chat, but again, as we're going through other presentations, please feel free to ask for questions. And maybe if you could now that we've had a number of presentations, you can sort of say at Burlington, at ETHB, at FLA, but we'll keep, there's lots of Q&A in the chat, so we'll keep the rest of it going. And we'll turn over. So thank you very much, Reham and Abby. And with that, we'll turn over to our next presenters. So Dendra Hillier, project manager, and Ali Summers, digital health lead with the Frontenac Lennox Addington OHT.
Awesome. Thank you so much. It's great to connect with everyone today. Thank you for the opportunity to speak to some of the work that we've been doing. So could you advance the slide? So the Frontenac Lennox Addington OHT is made up of over 80 partners. So this includes community agencies, municipalities, a very engaged community council, 160 family doctors, and 3 hospitals. We serve a population of approximately 210,000 people. This area is very diverse. It's composed of vibrant urban cities, picturesque villages along Lake Ontario, Tyendinaga Mohawk territory, and many rural and remote areas. You can advance the slide. So the FLA OHT received funding to begin the work on ICPs for heart failure and COPD in October of 2023. Similar to the other groups, we had early co-design engagements with our primary care network, community council, and Indigenous Health Council, which contributed to the development of the ICPs. Assessment before implementation revealed some key opportunities for change. So for heart failure, one opportunity in our region was that the care for heart failure was described as siloed care. No formal relationship or coordination really existed between the spokes, hubs, and the nodes. And this contributed to long wait times at the Kingston Health Sciences Heart Function Clinic. That is our largest regional hospital, and ultimately that leads to delays in care for people. Dissolving these silos would improve wait times and access to care. Additionally, the care provided by each level was another area for improvement. So spoke level care was seen as suboptimal in the primary care diagnosis and management, was not well organized with clear evidence-based pathways easily accessible to them. So this is an opportunity for education and implementation of those standard care pathways. Finally, community paramedics have the ability to respond to heart failure referrals, but this was not coordinated at the hubs or nodes in our region, and that limits the long-term effectiveness of their interventions. Importantly, each of the OHT partners has shown a deep level of initiative and willingness to collaborate and deliver best care to our population. For COPD, other opportunities were revealed. So the FLA OHT has a higher proportion of older people than average in Ontario and a significant rurality index. So what does that mean? Travel and costs can make it very difficult for people to access spirometry, for example, for COPD diagnosis. There's a real opportunity for the ICP to bring that closer to home for people. And care received by people with COPD was very heterogeneous, so very similar to heart failure. An opportunity to standardize that care pathway for primary care was seen as a chance for us as well. And lastly, neither of the two pulmonary rehab programs in our region provided virtual access to care. So in knowing our region, virtual pulmonary rehab has enormous practical advantages, considering we're a rural area and there was limited access to in-person rehab at the time of implementation. In addition, about 20% of our population does not have a primary care physician before our implementation year. So this posed a major gap in care and obstacle to implementation for the ICPs. The mission of the FLA-OHT is to have every single person attached to a people-centered health home, which will have the largest impact on people's health and wellness, including those living with chronic disease. So in generating a deep understanding of the current state of care for these two chronic diseases and being driven by our guiding principles, we began the work of implementing ICPs this year. If you could advance. So our team began identifying key initiatives that would expand capacity, create more efficient care transitions, and provide better access to services. So whether it be something like the pulmonary rehabilitation that I was just talking about, or access to a family doctor. So all of the initiatives were really aimed to address those opportunities for change that we identified. And I won't go into them in super detail. Hopefully we'll be able to share those slides after the session, and if you could advance. I would like to share just some of the results of these initiatives, something that we're really proud of, and some really incredible outcomes so far. So our team actually trained 86 personnel across the region, including 65 primary care providers. So there was a pathway document, that care management pathway. That pathway document, we educated those primary care providers on. We collaborated with them to create a shared understanding of the pathways. We trained 6 Ontario Health at Home nurses, 12 community paramedics, and 3 care transition nurses at Kingston Health Sciences. We hired 7 personnel, including a heart failure nurse practitioner, a heart failure physician assistant, a project assistant, a COPD nurse navigator, an ICP project manager, and 2 best care, they're called certified integrated disease clinicians, but we'll call them educators just to keep it easy. And then we also developed several new protocols. For example, the engagements with community paramedics. They have a home visit program, and we've established a new protocol with them to administer home IV Lasix. In addition, we created escalation and de-escalation protocols with Ontario Health at Home for heart failure. So a lot of this was creating efficiencies between different care providers and moving within their full scope of practice. Our team also reviewed emergency room data and connected people with the care that they needed, including connecting 50 people to a primary care provider in the region to receive care that they needed. The Heart Function Clinic at Kingston Health Sciences is our heart failure node, and it increased its capacity by 50% this year, decreased wait times by a median from 92 days down to 43 days. This clinic has also seen optimized specialist access as well. So based on our local available data, the number of anticipated new patients being seen within the Heart Function Clinic is actually going to be similar last year to this year. But what has changed is the category of patients. So the Heart Function Clinic is now seeing more urgent people through active diversion to the general cardiology group. So they're seeing more appropriate patients within that node, and that's resulting in better care. So if you could advance to the next slide. And to speak a little bit to the best care pilot, so we did embed 2 educators across 7 FITs in our region. So that included actually 10 sites. And our best care pilot resulted in 250 visits for people with COPD. More to come on heart failure. We just implemented last quarter, so we're waiting on that first set of data from them. But through best care, we learned that actually more about the people in our region, like their number of PAC years. So for our region, Best Care is actually seeing that we have a higher number of PAC years compared to the other folks that they're seeing across the province. Our goal classification is slightly different than the people that they're seeing outside the rest of the province. And importantly, Best Care worked to really shift the number of people on triple therapy and reduced the number of people on no daily controller therapy for COPD. So that could have a huge impact as well. So we're still in the process of gathering all of the data from the various initiatives, definitely more to come. But if you could advance to the next slide. So we just wanted to share a little bit about how the implementation went throughout the year to provide, we were talking about building blocks to success. So could you advance to when you see a green box on the right? I added a few animations in there. So over time, Q1 required a significant amount of ramp up. And I started with the team in May. Over the summer, we did implement several key initiatives. And after Q2, we actually started to see some changes. So the ICP implementation OHTs, they actually have a dashboard through Ontario Health, and that dashboard is available for us to check quarterly values against other OHTs, against the province. So within that dashboard, we actually started to see shifts in the admission rates and ED visits here. These values represent a % decrease up to Q2 as compared to our baseline year. So if you could go to the next slide for me. All right, and do the same thing. Thank you. In the fall, we ramped up and continued to build on our momentum with ongoing training initiatives. Rapid access clinics were launched. An important shift in our region was happening at this time. So the transition to Lumio, which is our new health information system for the entire Southeast region, that included all 3 of our hospitals. So that happened in December. This shift did result in changes to how we track, report, access data. It was felt from both the hospital and the community partner settings. And so it was really important to understand that impact as we did our implementation. Despite this, again, our ICP dashboard metrics continue to improve into Q3. We are waiting on Q4 data, so we'll see the full picture soon. And just for other ICP teams, if you are looking to do this type of analysis, like against your initiatives versus the dashboard, when OH updates the dashboard, you will lose the previous quarter's data. So I was actually saving the raw values in a separate Excel. So I just recommend if there are other teams that kind of want to do this sort of mapping to do that if you can. And you can go to the next slide. So here you can see our year-over-year trends for the region. Again, this is from the dashboard. Each of these metrics are trending downward. It's great to see. Again, more to come once Q4 is released. And just note that these results are occurring even while prevalence of both diseases is going up in our region. Also for outcomes relating to... Oh, I hear an echo. Outcomes relating to the Best Care pilot, they found that 38% of people that they saw had exacerbated the year prior to being seen, but only 2 people have presented to the ED since they've been seen by Best Care, and 0 have been hospitalized. So some really encouraging results out of the pilot as well. And if you can go to the next slide for me. So we mapped at the beginning, so now it's time to map since implementation. It's an iterative process, as the other groups have mentioned. Some key enablers for mapping include clearly defined care provider roles, ensuring that we understand the full scope of those roles so that stronger connections can be made between them. And you can go to the next slide. So tying this work back to the health home model, the ICPs complement this work by ensuring that those who are unattached are connected to a primary care provider, which requires integration with our PCN or care provider network. We focused on building capacity in primary care for chronic disease identification and management through initiatives like the Best Care pilot and collaboration sessions, or those education opportunities that we had. And working to streamline referrals and strengthen partnerships. We also enhanced resource navigation, similar to the other groups. They mentioned, resource mapping. We also did this. We created the map of our region, and it's available on the OHT website as well for the public. But we used it also in the work in designing the pathway. And if you can advance. So I would say, sorry. Enablers have been to recruit really highly engaged, respected, wonderful leaders. For as pathway leads, we are so fortunate to have Dr. Almifle and Dr. Fitzpatrick as our pathway leads. They have been such advocates for the work, and it really builds relationships when you have those people in those roles. Creating opportunities for connection and collaboration across the different providers. So doing those education sessions really turned into something really powerful. It built relationships across the providers in the region. And the pathway documents and maps allow for a shared understanding of the pathway and what it means for each of the care providers. Lessons learned: map your pathway early, identify silos and also overlaps. There may be some that are doing similar things. You should identify those early if you can. Tracks as many local metrics as possible. Highly recommend that. Understand each organization's priorities to estimate the impacts of implementation, especially partners tackling an internal transition like Lumio in our case. And establish MOUs and agreements early in implementation to avoid any delays. So if you have procurement that you plan to do, if you're hiring folks, those agreements are really key to move that work forward quickly. And with that, I'll pass it back over. I really appreciate it.
Great. Thanks so much, Jendra. Really great presentation. I appreciate your sort of implementation timeline and looking at some of the outcomes. I'll get people, if people have questions in the chat, please feel free to ask them. We'll have time for one quick question, which will be mine. And I'm just wondering, it was really interesting to see the outcomes, and I'm wondering what you do with those as a team. For example, is there sort of a committee that reviews them, or sort of what do you do when you get that information?
Yeah, absolutely. So I think, so we do have a kind of core team, backbone team, whatever you might want to call them. So these are the folks that are really working toward implementation. But we're always accountable back to the OHT's Transitional Leadership Collective, TLC, I believe, Council. So we bring anything back to them, and we have a biannual town hall with them. So we'll be bringing some of those results to the group and really discussing what that means for the future initiatives that could come out of maybe next year.
Great. Thanks so much, and thanks for sharing. With that, we'll move on to our next presenter. So we're going to hear from Melissa Chang from UHN's Integrated Care Program. And here we're going to shift a little bit. So we're learning from OHTs about their integrated care or clinical pathways and more sort of disease specific, although there is that goal of sort of broader integration. And here we're going to hear a little bit about planning care when it isn't specific to a particular condition. So thanks, Melissa.
Thanks, everyone. And thanks to all the presenters, because I'm really inspired by the work that you've done, and we've come a long way in terms of actually doing proper co-design with patients and providers. So kudos to everyone. I think when Walter and the team invited me to join, I think there were a couple of other factors as well. So one, we did not approach this starting from a condition-specific basis, but really looked at the overall UHN population, and largely that's across the Greater Toronto area. And then the other pieces that we, just to highlight in terms of the learnings that we can share, is one, we've been at this for about 6 years now. So we have a little more data, I think, than some of the other teams around, what kinds of impact we're making. And then the last is, as part of some of the work from a grant for CIHR, we are part of some learnings where we're looking at some common metrics and methodology on how to look at some metrics for integrated care programs across the country. So we've partnered with Alberta as well to look at expanding the work, what we've learned and what we can learn from them. So hoping to bring that back in future state. If we can go to the next slide, I'll go fairly quickly, and sorry, you can skip next. I didn't realize there was animation here. And one more, thank you. So just to set the context here is when we started down the path of integrated care at UHN, we knew we needed to start somewhere. And so we did start in surgery as a bit of a test of change and to evaluate how we would approach an integrated kind of model. And then very quickly, the plan was really expand across to all kind of groups across UHN. So really the idea is that any person coming to UHN would get an integrated care experience. Of course, that experience would look different depending on what kinds of support and the level of intensity they needed. But that would be phase 2. And we are now in at phase 3, where really are able to better take a look at population-based approaches. We started really in earnest around looking particularly at older adults. And that is really where much more of our efforts have focused on really being in the community, helping to prevent and support health promotion, and really looking at that whole person approach to overall well-being. So not just kind of a clinical or a kind of traditional health system focus. And so we're really at the phase 3 point right now. And if we can go to the next slide. In terms of the experience that we're looking at, it's not dissimilar, I'm sure, to what many of you have heard of. The experience that we really wanted, that we heard from patients they really wanted care coordination. So no matter what kind of approach we're taking, someone always has one consistent care team with a single point of contact that they can reach out to. And so that's been really critical to build up one collective team. How do you actually work together? Do you get to see each other? Do you get to be doing the rounds? How do you provide bi-directional feedback and availability? The next is really around continuity of care. So having one story to be able to tell. And that really includes having a shared digital record. Most of that, I would say, for the patient, it came across as a shared digital record and one, but it really was done with a lot of manual, we kind of call it the human middleware in the different transition points. And so happy to say that we're actually in the midst of creating that solution now for one shared digital record, where not only those within UHN, but our various partners in home and community will also be able to have read and write access. And then the next will be is having the timely and accessible. So, really having a number to call where someone can speak to somebody has been really critical and has really been a really great lifeline for patients, but also their caregivers. And then the last one is making sure that the care can be customizable to the needs. And really core to that, the how of what we focus on that for is having one integrated fund. So slightly different than what some of the bundles of funding might work on. We look at the path, we look at the kind of the needs together, and we really identify, where do we spend the dollars? So it's not necessarily, I'm Melissa and I'm going to spend, $200 on Melissa, but we're really able to adjust working with our different care partners. So I'll go to the next slide. I am going to focus, because we have the most data, on the pathways where I think a lot of the work that we have heard about to date and the great work that we've heard about on this call is really looking at, from a community lens, starting in community potentially. A lot of what I'm going to speak to, because I think it shows the clearest picture of the how for us, is that we have a much higher kind of acute care component. So these are where individuals might need to have much more connection back to a hospital, and making sure that we have that timely access, as people get back out into the home as well. So I just wanted to set that context that we are focusing a lot more on increasing higher acuity of care as well in these pathways. And so key to that work is really, the set of collective commitments that we developed with patients as well as our care providers in the organization. And so really, what does it look like when we address those care experiences? It means that you always have somebody to reach a person at all times, 24/7. If a patient or a care provider is reaching out to request clinical advice, we are responding within or under 30 minutes. And the other pieces would be having very clear action plans. So always making sure that there are escalation paths, if there are standing orders, medical directives, that somebody always has reach to somebody if within a hospital if required, and other partners as required. So that's been really key for us too. And then having direct care or admission, so not via emergency wherever possible. So that might be having direct outpatient clinic appointments, or perhaps it is us getting, you know, somebody from a home care team to the individual's house, like kind of within the same day. And then the last two are really, really ensuring, you know, that there are clear health equity to support, that we have clear mechanisms, that, you know, we're not relying maybe just on digital or remote when that might not be the case for everyone, and that there's continuous quality improvement with all of our partners. I'll go to the next slide. I'm not going to spend a ton of time on these next few slides, but really just to draw the concept of when we look at this experience, what's key is one of our huge learnings that we could never do this work without is how do you go about creating that one care team? And if you look above the top, kind of a traditional transition out from hospital, you might have your hospital team on the right side at the top with like own separate funds. And then you really start to engage maybe a hospital care coordinator at the time of the point of discharge, right? Those conversations earnestly begin. You've got another, you're introducing a separate contact, and then back out into, once you're back at home, you may have a different coordinator and then multiple providers that you're having to coordinate, which makes it pretty challenging for the individual and their loved ones. And then below would be all the separate, below is also a separate fund. So home care funds that you're operating under. If you look below, this is really where the approach we like to take, regardless of, you know, where the transition is coming from. But in this case, it would be having what we call as an integrated care lead identified right up front. So at the earliest point of a hospital admission, we're already looking at what is the expected length of stay and what are those barriers, and they're introduced right off the bat to the individual and their families. And then they're involved throughout the whole stay. So if we need or have difficulties with certain equipment, we're starting that planning right up front and getting it ready. So by the time we get to the expected discharge date, we are able to have a plan already in place, and that we've collaborated with whichever partners we need to along the way. And that person remains with this person all the way at the end, the recovery at home. The IC lead remains with that person until they are well. Generally, we have up to 90 days. If we're really seeing that there's a risk, then, you know, we may look at extending it. But that's really, you get it's one record, one number to call, one team that we're following. And I'll go to the next one just to highlight our ability to look at creating system capacity, because of course, you know, the patient experience was our first and foremost, but really to sustain this, we really had to look at how are we actually going to create and do more with what we have in the system today. So at the top, what you'll see is typically what we would see, right? You'd have somebody maybe admitted into hospital. That's the first event. They may, you know, they'll stay in event one. Maybe you come back and there's an event two and you're here for another period of time, and then a third perhaps. And so you can see how that kind of time and the number of difference of people that you might be connecting with. What we're really looking at doing is when we work with one team with our number of providers, we're looking at that first event up front, like can we reduce that initial length of stay earlier? And because we're linking and following an individual over a period of time, either can we avoid any sort of return ED visit or readmission, or if it's completely necessary, can we make sure it's happening sooner? So that if they do have to be in hospital, that it is a shorter period of time because we've caught it sooner. So that's the concept that in terms of showing how we're looking at creating system capacity, which is really critical to our sustainability. We'll go to the next slide, and I really want to make sure that that's just on the right side is just to share, you know, what the trajectory looked like for us over the past 6 years. We started slower. We, you know, navigated the pandemic, not without many bumps and bruises. But what we then did is really, over the past couple of years, really expanded quite quickly. So as an example, last year we went live in 15 different departments across the organization. And so that has been really key to, one, the sustainability of numbers that we're seeing, the consistency and the training of the different care partners that we're working with, so that they're trained in the same way. So what we know of in the hospital, also they know of in the community, and vice versa. And so our impact to date, I'm super proud of this, as I'm sure many of the other presenters have seen. Our Net Promoter Score is about a positive 79. And regularly we have 90+% patients rating the program at a 4 or higher out of 5. The number of bed days saved has been quite significant. So this is the estimated impact for about 4,000 patients on an annual basis. We are seeing, our target was in the first year is to have 1 day length of stay for every individual involved in the program. And so we are seeing at about a 1.3 average, and in some cases it's higher. We're up to 2 to 3 days saved per individual. And we are seeing definitely decreases in ED revisits and readmissions. And so you'll see that, our initial target was at least a 5% decrease in various pathways. In some cases, we are seeing a relative reduction up to 43% for revisits. And readmissions, in some cases, we're seeing up to 25%. It's of course not consistent across the board, but we are seeing that. And then I know we have our colleagues from IDS here on the call as well. But I think the other part that we've started to look at is what is the impact of this work, not only at UHN, but also across the region. And so we are seeing numbers where often, because of the trust and the relationship that has been built up, sometimes patients would like to come back to be seen at UHN. And so what we are evaluating and seeing is that that's actually having an increase across the region, in that while people may be returning back to UHN slightly higher, it's actually decreasing the capacity for other organizations across the province as well. And so I think just my last one, and I won't spend a lot of time, and I know there was a comment about text being really small. So apologies for that here. It's certainly not critical to look at all the fine point details here. But I think what we wanted to highlight is that when, we're all looking at the quintuple aim, what really is the difference for the how and what people see on the ground on a day-to-day basis. And so if we look at the patient experience, it may mean that, somebody has left the hospital and they're experiencing some complications or some concerns. We are able to get someone there, like they're able to call the line. There's always a nurse on call to be able to clinically assess the individual. And in many cases, we're able to get a home visit within the same day, sometimes within the hour. And so those kinds of things really alleviate and really allow people to go back and feel safe in the comfort of their own home, and know that they can be connected back into hospital if required. The other is around patient satisfaction, and I see you, Kaylee, coming up. Time to cut me off here. So I think the other pieces I'll just quickly highlight is that we are seeing that from a provider satisfaction is having that link back to their colleagues has been really critical for them to feel like they can best support the patient at home. So really having a better understanding of the patient, a check-in, is this normal to be recovering at home, has really created not only satisfaction that people can close things off while they're in the home, but also a confidence that they're being supported by a broader team. And then I won't spend too much time on the others, but we really are looking at shifting care away from hospital then into the home. And what we've heard from, let's say, our home care providers and community paramedicine in this case, they've really benefited from the shadowing and learning on the ground with our hospital teams and vice versa. And so they're taking on more of what would have traditionally been able to be done in hospital. And so seeing lots of value from that. I will stop there, Kaylee and team, and I'm sure there are some questions.
Yeah, thanks so much for that. I really appreciate great presentation. Also really nice to see sort of how you're defining success and some of the outcomes as well. I want to make sure we have a bit of a time for sort of the overall reflections on kind of the success factors and challenges. So I'll get There are a couple, I'll draw your attention to the chat. So if there are a couple questions there for you, and if there are more, keep coming if you can respond there. And with that, on the next slide, it's just that I'm going to turn it over to Gaia to lead us through a couple of reflections and a panel discussion with about what we heard today.
Okay. Thank you, Kaylee, and thank you to all speakers today. Really interesting presentations. I really appreciate the focus on the how, Melissa, in the last presentation there. So I wonder if you can all perhaps go on video. Great, thank you. So maybe I'll just start with big picture. And you've probably spoken to this in some form in your presentations themselves, but you've all already identified, I think, a number of things that you've put in place or done that have really helped you along this journey towards implementing ICPs, right? So I'm just wondering if you could perhaps pick one or two things that were just absolutely integral in this journey, and maybe talk a little bit about, what activities or what changes were put in place to enable this. So, I'm hearing some of you talk about the importance of tailor-made care pathways, the importance of a change in attitudes. So you're thinking about these as care pathways and not clinical pathways, right? Then a lot of co-design, resource mapping, that sort of thing. But, and feel free to pick up on any one of these things. But is there anything else that was unique to your program that you'd like to talk about, and the activities and, any changes that helped this happen?
If you want, I can go.
Great, thanks.
Yeah. So I think something that emerged as we were doing the work, we designed these education sessions. So we went out to the FITs in the region. We had a pathway document catered to kind of their practice and what was needed, grounded in the quality standard. And we had lunch and we talked. And I think the biggest thing that came from that was really like integration requires conversation. So you will find where the resistance to change might be at different organizations. You might find that there's new opportunities for collaboration. A lot of stuff came up during those conversations where we said, oh, we can fix that. Let's go ahead and work together on a way to fix it. So that was something that from an initiative standpoint turned into a bit more of a theme, which was speaking and communicating with one another and finding better ways to work together.
Excellent. Graham?
Thank you, Gaia. I think in Burlington, both the biggest challenge and the opportunity was in trying to kind of position clinical pathways with an integrated care system. How to do a clinical pathway with an integrated care system. I think this is the question that we started, like the first one, to think about when we were thinking about co-designing clinical pathways. And then we came into this understanding and agreement that maybe it's not a clinical pathway, it's a care pathway. And maybe we need to think about the whole journey and try to understand, well, where are the gaps and address them. But also one thing that happened when we're talking about care pathways with an integrated care system is just like trying to maybe better align the relationships between different partners within this big journey. So for some of our engagement work, this was the very first time that the primary care and the specialists sit at the same table, thinking about how to integrate the work together. For many of our primary care providers, it was their very first time to understand that there are lots of community organizations providing community-based programs for chronic disease prevention and management. So this was like an aha moment for all of us. And we're like, yeah, this is an integrated care system. It's all about understanding what's out there, identifying the gaps, and then find the alignments and build the system as we go.
No, really interesting. And thank you for pointing out, because my next question was going to be, maybe talk us through a key challenge you faced and how you went about dealing with it. But, as you point out, they're not necessarily two separate things, and the opportunity and, actually dealing with it can both be, a challenge and something one at the same time. And it's interesting that it sounds like Burlington very much sort of layered in, a consideration for spread and scale in the very at the very top, the very beginning. Okay. Anyone else? And feel free to jump right into challenges as well. You know, what key challenges did you face and how did you go about negotiating them?
Guy, if it's okay, I'll jump in just on
Please.
the first question. I mean, I'm going to be a bit more pragmatic about some of the success reasons, as we were given dedicated funding.
Yeah.
For many, I really commend UHN for having the foresight to invest in it. Many hospitals don't have the foresight to invest up front in integrated care. So we were actually given dedicated funding, and that funding wasn't flowed through a particular provider. It was flowed to the OHTs whose job it is to integrate people. And I think that kind of system was a good trial for us to figure out how to do better integrated care, is flow it through the OHTs and make a dedicated focus on integration. We need seed funding to get to those lead metrics about reductions in admissions and stuff to go back to our institutions, because maybe we don't have as much foresight as Jen to go back and say, we now can save you days, give us that money back to reinvest in integrated care. We need those seed fundings to prove those outcomes.
Good point. And I'd love to know where all of you maybe chose to invest that seed funding, if that's something you want to share, because it sort of indicates priorities and that sort of thing, right? But yeah, Melissa?
Yeah, and maybe this will go to some of it. So I appreciate Jeff getting really practical with all of us. And I think for us, one of the questions was, funding is always going to be a challenge. I think we worked with one-time funding and still are, quite frankly. But one of the tricky things that we had to do, and I'd say it was I don't know, it could go either way, but we had to decide either, this work takes a lot of engagement and co-design, as you've seen from a ton of people here, like a large portion of the conversation is that it's critical. But when we talk about sustainability, it doesn't always feel like we have that ability. So what we landed on doing was creating that core foundation of what the core experience should be and choosing to go really fast over the past 2 years. And sometimes that resulted in, you might walk into UHN and say, hey, I heard about your integrated care program. And someone would say, I have no idea what you are talking about. That still happens all the time. But what we did is, try to put the foundation in, which allowed for the teams in the hospital and the community to learn from each other about what they do. And that cohort started to grow. And they really were the ones that really then started telling each other, hey, this is a better way to do it. Why aren't you, my colleague, doing that? And we didn't purposefully actually go out to do like any sort of shaming. We just believed in the model so much, and we thought it would speak for themselves. And that's a trade-off that we had to do, was do we go really fast and know that we're going to have to cut off some of that co-design and awareness building, which we know is going to come back to bite us in some cases. But it then allowed us to, one, put a foundation in place. So now we see the innovation and the ideas coming across the organization. And the other is it allowed us to train up dedicated team members to allow us to do this work. And so those are some of the trade-offs when we're thinking about the balance here.
That's so very interesting, Melissa. Thank you for that. And yeah, anyone else, feel free to jump in on that first or second question on, what were the sort of activities that helped, as well as key challenges and how they've negotiated. But just moving on to this piece on spread and scale that we seem to be talking about here. I wonder if others could also talk about your approach to spreading this to other, conditions. You've already said, many of you, that we're thinking of this as a care pathway, not necessarily a clinical pathway. So there is that, but how are you thinking of, including other populations within your area in this model? Are you, is it similar to what Melissa was talking about? Are you going a bit more slowly, and what are you taking into consideration? Graham.
Again, that's a very great question, Gaia, and maybe a couple of thoughts based on our experience in Burlington. So very early on, we were doing these early engagements with especially with our primary care providers. They were like, this is not the very first time that we hear about clinical pathways, and we don't think they work. And when we asked them, why don't they work? They said, because they're very disease specific, and we don't see diseases, we see patients. So we need a system. We don't need just a clinical pathway for COPD or heart failure. or whatever other chronic disease is. And the second point is that most of the time, the provincial priorities doesn't align 100% with the local challenges or priorities. So for instance, we were looking at the average, like why Ontario Health selected COPD and heart failure, just because they are causing like lots of system burden. However, if we're looking at our local context in Burlington, we are among the higher performers in COPD and heart failure. So why bother? And why work with all our providers if like nothing more can be done? So again, thinking about the system rather than the disease, and thinking about the journey, and how can you not just start from the hospital and then go forward from that? How about before the hospital? How if we are putting some pathways that would support not going to the hospital in the first place? So I think these are all the considerations that are very backed up by integrated care thinking, but they're not among the very formal way of thinking about clinical pathways.
Yeah, no, thank you. Ali.
Yeah, I
And then
really
Melissa.
loved that framing, Reham. I think we're taking a very similar approach in FLA, and especially looking at the spin from Ontario Health over the last couple of months towards the chronic disease prevention management models, as opposed to these clinical pathways. I think that really lends itself to how we can shape this work into being more sustainable and scalable for local needs. One of the things I think is important to like zero in on here, though, is not just abandoning the work of CHF and COPD and immediately jumping to another pathway. Otherwise, I think there's a very significant risk that the really great work that's been done to date will just kind of crumble without the resources in place. I think to Jeff and Melissa's point, like you need that investment to have the right personnel capacity to make these programs run effectively. And we are starting to see really great outcomes as a result. I think we probably need another year or two of really dedicated support around our CHF and COPD pathways to continue to demonstrate the results and make sure that they're running smoothly and integrating with, especially in FLA, our health home model, which we're trying to focus in on. But then also looking at how we can proactively plan for the future. So we're doing a ton of data analysis to better understand our population, right down to the neighborhood model. So different areas of our community will need different resourcing. And so how can we put the right resources in place in those communities to Reham's point, prevent that hospital admission? And we're also doing some work with our specialist network in the FLA region to understand, also where are the specialty constraints, like how can we move some specialty here into the community to offload some of that work in the hospital to free up some room for more pathway focused work and procedure space. So I think that's some exciting work to date. And I think based on the data so far, our natural next step would be around diabetes and lower limb preservation. We're seeing that as a high priority in our region, but just wanted to really flag that there's a need to sustain the great work that's happened so far before we just jump into a net new pathway.
Thank you, Ali. Melissa?
Just really quickly, I would just say that we are expanding more to focus on the older adult population in particular to support. And I think that's where the amazing work that's already happened with these pathways, I think, is another element to bring into this, is because what we're seeing with the older adults is they're the ones who are driving how and where do they need the care, thinking about mobility, thinking about health promotion and prevention, like as way more upstream than we normally do in the health system. And I think that's a really exciting place to be, is really bringing that into the fold. And we're not only seeing, obviously the excitement of it, but it's the capacity the community is bringing as well. So not only are they kind of doing the work to say, I can put posters up in my building if you're going to come do a wellness clinic or something, but they're also the ones that are going to get their neighbors, making sure they show up for appointments or education sessions and helping each other do it. And so I think that's an untapped part of, really hugely doing integrated care really well, is how are we enabling the community to do it for themselves? And I think that's the next part that we're kind of heading into as well.
Very nice. I feel like, unfortunately, Kaylee, I'm going to have to throw it back to you. I could talk to all of you for another 1 hour at least, and maybe I will get that chance at some point, because we are beginning to, start doing some evaluation work with ICPs going forward. So who knows, we shall hopefully meet again. Thank you very much for all your contributions, all of you. Kaylee?
Yeah, thanks. Thanks, Guy, for leading that discussion, and everybody for your reflections. It's always really nice to kind of to hear what it is that's sort of a driving force and how it's going. So again, thanks to all the presenters. I just want to highlight what's up next for the HSPN webinar series. So we're taking a spring break. It is technically spring in May. And so we'll be skipping May's webinar, but we'll see everybody back on June 24th for the next HSPN webinar. And then not in that slide, I also want to highlight that the community of practice we'll be revisiting the sort of ICP topic in one of the coming sessions, and more so focusing on how people are evaluating it, not just what they're doing, but sort of digging into that aspect of it. So once again, thank you to all the panelists. I really appreciate you taking your time to share and offering such great insights. And thanks. Goodbye, everyone. See you in June.